and post call. So it's hopefully get to enjoy it a little bit. We had doing a couple projects around the house, which is nice. So, but yeah, thank you for inviting me to this talk. If you are recording, that's perfectly fine. Go ahead and record the presentation. I'm going to share the screen in just a few minutes, and it'll go over my presentation. So we'll get started from there. And then, like McKenna said, the chat feature, I did go ahead and put my email in there. So feel free to email me with any questions throughout, or after we finish the conversation today. All right, this is the first time I shared stuff. So let's see if this thing works. Okay. Grant access. McKenna, is it recording?
Yes, it is.
Okay.
Are you having issues sharing your screen?
I don't know. Are you able to see it? Desktop one. Let's see if this works. Share.
I'm not able to see it yet, but.
Okay. It's giving me, let's see. No, I don't need a login. It's giving me security stuff, so I'm not sure what that means.
I can try and make you the host and see if that helps.
Okay.
Okay, so you're now the host.
So let's see if this works. Oh, it's saying my settings under my Mac. I'll change them. So let's see if I can find that real quick. So yeah, sorry for the technical difficulties.
No worries. It might be under like your system preferences.
Yeah, that's what it was saying. There's Zoom. No, it's enable. I'm not sure. Let's see if we can do it this way.
If you can't figure it out too in a couple minutes, you're welcome to email me the PowerPoint and I can share it, and you can just tell me when to click if you like.
Okay, let's see if I can do this. It says, open my system. Oh, allow the apps. Yeah. To lock to make changes. Oh, there it is. All right, let's see. It won't let me. I've never had this happen before. Let's do that. Let me just email you, McKenna, this presentation so we can get it going.
Okay, I'll put my email in the chat right now.
Okay, that sounds good. All right, perfect. It's a big presentation too. Let's see. I think it's like 10 megabits, but we'll make it work. We're going to get it fixed up. Let's see. Let's see if this works. All right, I just sent it over. So let's see if we've got any luck on that.
Okay, awesome. Thank you.
Yeah, and in the meantime, while we're doing it, I'll see if I can share the screen again.
Okay.
We'll figure out one of us will make it work.
Yeah.
So McKenna is saying, in order for me to these settings to change, I have to quit and reopen Zoom. You want me to do that real quick?
Yes, but before you do, will you make me host again? Because I don't want it to like kick everyone out.
Yes, good call. All right,
Okay.
so the Zoom, let's see if I can find it. How do I change back to the host?
So hover like over my screen, my little
Yeah.
picture, and then the 3 dots. Click
Okay,
that.
change host. Let's
Yeah.
see if that does it.
Okay, I'm now the host. So you should be good to like go out if you need to change something in your system preferences and then rejoin.
All right, let's do it. Quit and reopen. All right, so let's see if we do it. I'll rejoin and see if this works. All right.
Okay,
Be
perfect.
right back.
Thanks.
All right, bye-bye.
While he's out right now, for everyone who's asking about the attendance or like volunteering or shadowing hours, Margaret and I will create a quiz for this Zoom session probably within the next couple of days and send it out. And then you guys can have record of that you were at the series. So
I have a computer audio. All right, let's see. All right. Am I back now, McKenna? Looks like I am. Let's start my video. All right, beautiful. That's one. All right, we're good. And then we're going to share the screen this time. Oh, I think we might have it to share the desktop. All right.
we can see it.
Look, I guess it's, I'm not as computer savvy on these Macs as my wife is. She just stepped in and goes, "Now you're a millennial." I mean, shoot, 30 years old.
Well, Zoom is finicky too, because sometimes it works for me, sometimes it doesn't. So no worries.
Oh, yes. All right. So let's see. Let's get this thing right. So sorry for all the technical difficulties. Now let's get this party started. Let's see. I can go here. Boom. Okay. So yes, my name is Dr. Mark Hylton. I'm an anesthesiologist with UNC. However, I am based in Goldsboro, North Carolina. So if some of y'all don't know that UNC Health has, I believe, 11, don't quote me on that, 11 hospitals that UNC Health is affiliated with. Either they own or have a management agreement to. With that being said, UNC faculty physicians, which is is my employer technically, as I'm employed through the Department of Anesthesiology and the School of Medicine. We are at a few of those sites. We are not at all of the facilities. And one of those is down here at Wayne UNC Healthcare in Goldsboro. So we'll go ahead and get the party started today about paging the anesthesiologist and talking about sort of my day-to-day life and how I got to where I am. I have no disclosures, no financial disclosures to talk about today. So the overall objectives, we're going to do it in probably about 30 minutes and then open it up to questions. So I wanted to sort of discuss my background and journey today, sort of go through about applying to medical school, just a brief overview, as some of y'all may be doing that now or in the process soon. Talk about what is an anesthesiologist. We'll describe the specialty and the subspecialties that are within it. Talk about a little day in the life and some tools of the trades that I use and so forth, and then we'll open it up for questions and discussion. So a little bit about myself. I was born in Danville, Virginia, so not too far north of Chapel Hill, about an hour and 15 minutes. It's really about 2 hours and a half from Goldsboro, so it's not too far away. I went to Virginia Tech for my undergraduate, of which I received a degree in human nutrition, foods, and exercise. That was one of the pre-medical majors there. And so, as always, go Hokies. We're competing pretty decent with Tar Heel basketball these days. Football team is so forth, and baseball does well, and the women's sports have done an amazing job as well. So, I am a avid Hokies fan. I then, after finishing up there, I moved from Blacksburg, Virginia to Richmond, Virginia, where I started medical school at VCU Health, also known as the Medical College of Virginia. I did medical school and residency there. So I graduated medical school in 2016 and then finished residency back in June of last year, so June of 2020. I was one of the chief residents, and so I had some administrative and leadership roles within that. And then as of, took about a month off to take boards, and then started down here in Goldsboro back in August of 2020, where I joined as a clinical instructor for UNC, and then a staff anesthesiologist at Wayne. This is my family here. There's my wife up here in the right corner. Very thankful for her to allow me to do what I do. And then you see our daughter here. This is little Cora. So we just put her down for a little bit of naps. She takes a nap from about 12 to 2:30ish or so. So it worked out pretty well. And then our dog Trudy. So that's all of us right there in the bottom so far. Now, we want some more kids later on in life, but this is our family for right now, and definitely it's a joy to be with them, spend time with them as much as I can, despite the work hours of residency prior to starting here at Wayne. My journey to become a physician. So back when I was in high school, I started as worked as an EMT, volunteer with the Damn Life-Saving Crew. I was a member for about 9 years, where I was an EMT basic. I did special operations, including extrication and swiftwater rescue and scuba diving and things. Then I went ahead and did a lot of shadowing. So I do recall shadowing a cardiothoracic surgeon, and that gentleman was in Danville. I shadowed a couple orthopedic and general surgeons as well, and then got some experience within the primary care. Just here and there to sort of dabble in and see what medicine was like and to see what the career was about. I was very fortunate that my grandfather was a physician. He was a radiation oncologist. He was based in Danville, and got to talk to him a little bit about it. And I was younger, but unfortunately he passed away in 2006. So I was a teenager then, but didn't have the as going through the application process and looking at medical school and things, didn't have a physician in my family to rely on. So I worked on, lean my hand to some friends of mine, as well as these surgeons and physicians that I shadowed and developed relationships with. While in college at Virginia Tech, and I got some more experience within sports medicine, is what I initially thought I was going to lead my career in, I guess. And that was considering really sports medicine and orthopedic surgery. And so I was a student athletic trainer with the football and basketball teams there, and got some experience with our team physicians, and they were great leaders, very knowledgeable, and taught me a lot as I was there. And still applying to medical school at that point. And once I got in, I was like, still want to be an orthopedic surgeon, until I got, right into probably first year or two, met a couple anesthesiologists, and sort of my career goals switched. And so with that being said, when you make your own path to becoming a physician, either a medical doctor or a doctor of osteopathic medicine, both are great paths to take. Neither one I don't feel is better than the other. We're all physicians. We're all here to take care of patients. I do say the osteopathic physician, the colleagues of mine that I've worked with, sometimes even have a leg up compared to some of our allopathic physicians, because they get some training in manipulation, in osteopathic manipulative medicine, some techniques that they use to treat illnesses and disease processes. And I don't know all the details about it, but love to learn it. And so I have my DO colleagues, I sort of lean to them and like, hey, teach me some of this stuff, because it's very interesting of how they did that. So when you design your own path and start on this journey, it does take a lot of time. It does take a lot of effort and energy, but keep that good support system with you. And that's your family and friends to lean on when times get tough, because it will not be easy all the time. when you're in undergraduate, you can take any course of study. You don't have to be a pre-med major or biochemistry or anything like, or biology. You can study anything. You just have to take certain prerequisites, and that's sort of outlined on the AAMC's website, along with taking the medical college admission testing. And I believe it's changed a whole lot since I've taken it. It's almost been 10 years that I've taken it. So definitely changed over time. And with COVID, that's another aspect that's changed and led us down a different path. So you'll type up and work on a personal statement and essay throughout things. And that's, sort of key in what, admission officers for medical school look at is your personal statement. They do like to read out of why are you, why do you want to become a physician? What kind of work led you to that thought process? The volunteer work and community service is another big component of building your resume to become a physician. And so working in that, so that's either volunteering in a health profession like I did, or various other community service works. I think back just recently, a classmate of mine in medical school, her name is Shika Gupta, and she just got named in Time 100's magazine. So she is leading a organization called Get Us PPE regarding COVID. And it's amazing to see what she's done prior to that. And if I recall, I think she went to UVA, and she was amazing. I mean, the resume that she built in community service work was amazing. And that's why she's doing what she's doing today, and is a great leader in our field. From clinical experience, that's just going to take getting those shadowing opportunities, working with physicians and healthcare professionals in your community to establish that experience, to get an idea of what we do on a daily basis, and then joining conferences like here. With COVID, not everybody can be in person all the time, unfortunately, but even these opportunities are very helpful. And I was very grateful when I got your email regarding this. I was like, wow, this is an awesome opportunity. So thank y'all again. So what is anesthesiology? What's the specialty about? We'll get down to the nitty gritty. So it's a branch of medicine concerned with anesthesia and the anesthetics that we provide. It's works with the total perioperative care of patients before, during, and after surgery. So that's take place from the preoperative arena. When the patient has seen their surgeon, they're going to get X surgery, and they come and get, if they need any extra test or they need an evaluation prior to coming to the operating room. We may see those individuals in a clinic, but we don't staff a clinic every day per se. We do have down here at Wayne. I'll give you a little background. We have a pre-admission testing clinic, and so it's staffed with our nurses, a nurse practitioner or PA, and then we also assist. They'll call us if they need to. So, for example, like I think on Friday, there's a patient that I'm going to have to go see when that individual comes into the clinic to get their preoperative testing done and chat with them about their anesthetic plan. However, where I trained at VCU, we had a pre-admission testing clinic, and that was very large. We had probably any given time 6 to 8 healthcare providers, including residents, nurse practitioners, physician assistants, nurse anesthetists in that clinic with us, all seeing patients. And we would probably see 40 to 50 patients a day in that clinic. But staff with a lot of people do that because we'd spend 30 to 45 minutes with each patient talking about preoperative workups and getting them prepared for surgery. Within some aspects of where do we work at? So we do work in the operating room and provide anesthesia, and I'll talk a little bit more about that next. Anesthesiologists can then do fellowships within pain medicine, and a fellowship is those subspecialties that's listed below, and it gives you usually an extra year of residency. So within anesthesia, we do 4 years of medical school, 4 years of residency, which we're employed by a health system and training during that time. And then individuals can do an extra year of training in pain medicine, and they do like interventional pain procedures and treat chronic pain and even acute pain. There's critical care medicine. So anesthesiologists, we are critical care physicians in the operating room, in the perioperative arena. And so their classmates of mine went on and did a critical care fellowship. I've got a buddy of mine who is at Johns Hopkins right now. And as you can see with how COVID has evolved in this pandemic, anesthesiologists have played a vital role in that, and especially the critical care anesthesiologist. But all of us are trained in that to where we can, be shipped to an ICU and take care of patients if we need to. We help out on the obstetrics floor. That's where a lot of ladies meet us when they request their epidural. And so, for example, last night I was on call. We finished up operating room cases for probably about 6:30, 7 o'clock. There was one lady upstairs that had a feeling would want an epidural at some point before midnight. And so I went up there and saw her prior to leaving the hospital, and went ahead and just placed her epidural. She's like, yeah, I'm ready for it. So come to find out, about 2:30 this morning, I think she had her baby, and she's doing great. So then also within the specialty of anesthesiology, there's, we work with our emergency medicine and ER physician colleagues and assist down there as needed, including mass casualty incidents, traumas, and so forth. So as these subspecialties we talked about, there's a cardiac anesthesia fellowship, and these anesthesiologists take care of heart surgery patients. So when patients have open heart surgery, coronary bypass surgeries, heart valve surgeries, and so forth. There's obstetric anesthesiologists who've done an extra year in training to focus on the high risk obstetric patients. There's a year you can do in pediatrics, and pediatric anesthesia, working with the very sick pediatric patients that we may see, and work in maybe like a children's hospital, so sort of a children's hospital in Chapel Hill. You have the acute pain physicians and the chronic pain anesthesiologist. Then there's also regional anesthesia, and we may talk a little bit more about that in a few minutes. There's the critical care anesthesiologist I talked about, and then there's fellowships within transplant anesthesia, and these anesthesiologists tend to take care of patients who maybe need a kidney transplant, liver transplant, pancreatic transplant. You tend to see your cardiac anesthesiologist will do your heart transplants and your lung transplants, but you can also, those two types of anesthesiologists who have an extra year training and such can do both, and may do both depending on what center they work at. There's neuroanesthesiologists who tend to focus some of their extra training and time on patients requiring brain surgery or significant spine surgery. And then there's trauma anesthesiologists too. So a lot of us may work in trauma centers, or at least train in trauma centers, and we get exposed to it. But there are some individuals who do an extra year of that and sort of bridge trauma and critical care and things like that. Even with all these subspecialties, for example, myself, I did not do an extra year of fellowship. I did my 4 years of residency, but I got exposed to all aspects of this and feel comfortable managing all of these patients. Now, for example, though, I'm not a cardiac anesthesiologist. I can take care of patients who have heart disease, but we down here at Wayne do not do cardiac surgery. So those skills that it made to take care of those patients. Like I said, who is an anesthesiologist? Those are physicians who specialize in the perioperative care, develop the anesthetic plan, administer the anesthetics in the operating room, and most of them work in a care team model with a nurse anesthetist or an anesthesiologist assistant. Biggest thing we do is we ensure patients are safe when they're undergoing surgery. And we manage much more than just the ABCs or the airway, breathing, and circulation, but we manage nausea, pain, hemodynamics, intravenous access, and so forth. And then lastly, I definitely want to pay my respect to to our individuals and my colleagues who have dealt a lot with COVID during residency. So my chief residency, like I said, last year we did, as a chief resident, take a lot of scheduling time of where we were as residents getting shipped to the ICUs and to other portions of the hospital to assist in managing patients diagnosed with COVID and having severe COVID and intubating them and putting different lines in and access. So it's been definitely a stressful time. It's given us, found respect for our specialty, found respect for the patients, and taking care of them. So it's definitely been, I think, rewarding. Definitely has for me, but it shows respect for all healthcare professionals as we take care of these patients and go through this pandemic. So let's talk about the day in the life. Now that is not me, but some days I may look like that. So usually my typical morning, I'm up at about 4:30 is when the alarm clock goes off. Why? Because since June or July of last year, my wife and I both have been working out, and we work out in our home, fortunately. And so we try to work on our exercise routine. So now that I'm not having to study as much per se, I still do some reading and work, but I'm not dealing with the resident schedule and hours. I'm able to focus on myself a little bit more. And I get my workout in, and then I'm usually out of the house and arrive to the hospital a little before 6:30. About 6:20, I get to the hospital, 6:30, something like that. And tend to work between up until about 3 o'clock or so. Most of our cases in the OR will start around 7 to 7:30. And there may be a day that I'll take care of anywhere between 8 to 20 patients over a given 8 to 10 hour shift. If I'm done by 3 o'clock, then, from about 3:30 on, occasionally have a meeting a couple times a month, try to spend time with the family, continue studying. I still have one more set of boards to take, and that's usually oral boards that I will have to take. But with COVID, I'm not sure when I'll have to take those yet, and things like that. So that's usually my family time, anywhere between 3:30 and 8:30, and then it's off to bed by then because I'm up at 4:30 the next morning. So usually my typical call schedule is I take about call once a week. So last night was my call night, and so I went into work at about 6:20. I was the last one to leave, and we finished, like I said, about 7 in the OR, and then I had one epidural to put in, and then I was home on pager call. And I think about 1:30 they did call me. Labor and delivery did touch base with me regarding the lady with the epidural. But otherwise, sometimes I'll get paged to have to go back in. There are times that I'll get paged at 9 or 10 o'clock, and I may be there all night. And that was a couple weeks ago. So the call schedule, it varies. Fortunately, I live 15 minutes away from the hospital, so I can stay at home when I'm on call. But some of my colleagues live greater than 25 to 30 minutes away. And so that's our callback time. And if they live outside of that time, they have to stay at the hospital. So about once a week, they're staying at the hospital, and about one weekend out of 5, we take a weekend call. So I usually start my weekend call on a Friday morning at regular time. I'm the last one to leave on Friday night, and then on pager call throughout the weekend all the way till Monday morning at 7 o'clock. And usually we're doing cases on Saturdays and Sundays, and it varies how many we do depending on the need of the surgeons and the patients. Some tools of the trade. So these are some things I was talking about that we may use, and we're going to go through some of them. So over on the left side is a bronchoscope. So part of anesthesiologists, we do have some cool toys to play with, and that's one thing that interests me within anesthesia. So this is a bronchoscope. This is a camera that we use to go down into the lungs to actually visualize them. We visualize this sometimes to place a breathing tube is mainly what we use this for ourselves. This is a laryngeal mask airway, we call it. It's a device that we can put once we push patients to sleep, we can use this to help breathe for them. You can either use this type of device, or you can use an endotracheal tube over here on the right. Right here in the middle of the screen is called an arterial line. So this is a little IV catheter that sits in the radial artery, which is right above your thumb. And we'll put that in to watch the blood pressure beat to beat when during surgery if we need to. Not every patient needs one of these, but some patients do. And if we need to, we'll put those in. Down here in the bottom corner, this is a transesophageal echocardiogram. And so this is an ultrasound device that goes into the esophagus, so the swallowing tube. It goes down and sits right behind the heart. And these are what cardiac anesthesiologists, this is really what that year of training and fellowship, along with transplant anesthesiology, they get to build skills to use this, to interpret this, and to read these studies to do. So part of their fellowship training is to then get enough cases and perform these and interpret them to become certified to do them. During residency, I had the privilege, and all of us do as part of residency, to do transesophageal echocardiography. However, I'm not able to write a report on it per se. I can do some basic interpretation, but unable to do the report. So that's what my cardiac anesthesia colleagues, my transplant anesthesia colleagues get some experience within that. These are some other toys that we get to play with. One's the laryngoscope. So this is an anesthesiologist or a nurse anesthetist putting the breathing tube in on this patient. So they use this blade to move the tongue out the way, to see the vocal cords, and to place that breathing tube in. This is another form of a bronchoscopy, or the bronchoscope, the camera to put the breathing tube in. This anesthesiologist here is putting in a central line. This is a big IV in the neck using the ultrasound machine back here for IV access. This anesthesiologist here on the bottom left-hand corner is using the ultrasound machine to look at the heart. And this is called transthoracic echocardiography. And this is a technique that cardiologists use, as well as anesthesiologists and critical care physicians. ER physicians get training in this, and any physician can. Personally, I do a lot of this type of echocardiography in the perioperative arena in part of my training. So fortunately, I did get a lot of experience and still use this. This is a great machine, by the way. We have a few of these down here at Wayne, and it gets beautiful images. So this appears to be down, it looks like a guy that may have been in a trauma, and they were doing a type of exam on him. The bottom right-hand corner is actually an ultrasound image of the brachial plexus. So where these yellow dot triangles are pointing are a bundle of nerves. And so I mentioned when I talked about regional anesthesia, and this is, regional anesthesia is a subspecialty that anesthesiologists use to inject local anesthetic or numbing medicine around these nerves. And so we use a needle under ultrasound guidance, come in and deposit numbing medicine around here. Very similar, the numbing medicine is very similar to what the dentist uses. It's usually the type I use much longer acting. And so I can numb those nerves up, and a patient can have finger surgery, hand surgery, wrist surgery, elbow surgery, shoulder surgery, numbing these nerves up. And so I can do a full block on, we call it a nerve block, numb the whole nerves up with local anesthetic, give them just some sedation in the operating room, and they will have no feeling in that arm and can have surgery. I also implement this type of anesthesia on patients that need foot and ankle surgery or leg surgery. And I can use an ultrasound machine to also numb and look at the nerves in the legs and deposit local anesthetic around there. These are some common medications that we use. We talked about using the local anesthetics. Here's propofol. This is probably one of our major agents, our induction agent. People hear about that. There's a sort of a tray right here that talks about, or it shows different medications that we may use. And this one up top is probably just a list of a standard 4 medications that anesthesiologists and nurse anesthetists provide to patients to get them off to sleep prior to surgery. We use ketamine as a anesthetic agent that we'll use for induction and help with not only will it get patients to sleep, it will help with pain relief afterwards. So it's a great medication and adjunct to use. We do use midazolam as another agent that we'll use for anesthesia and to take away some anxiety for patients prior to going to the operating room. And then we do use narcotic agents. So there's fentanyl. We use morphine, Dilaudid. These are names of medications that we use that are controlled substances. So we are very cautious with how we use them. We use them very judiciously when needed, but know that they play a role in the anesthesia and to help pain control afterwards, but we limit how much we need to give patients. I think that may have been the last slide. I do have my contact information here. It's my business card. I'm going to put a picture on there. So I've got all my contact information. If you need anything, you can reach out. Like I said, I did put my email address on there. And then lastly, we'll open it up for questions and discussions with y'all, if you have any.
Thank you so much. That was a great presentation. So
you're welcome.
We have a good amount of questions in the chat. I'm happy to read them to you, or you can read them out of the chat. Some people prefer different things, so it's completely.
Let's just see if I can pull up the chat message. All right, so let's see. All right, somebody put a quiz. So that's not for me. All right. Okay, I'm doing this. Okay, perfect. So someone asked, any concerns with not being needed due to the rise of CRNAs and AAs? And that's a very good question. Within the Society of Anesthesia, within our community, we do work with, in a care team model, nurse anesthetists and anesthesiologist assistants. So in some areas, nurse anesthetists can practice independently. And here in North Carolina, they have the opportunity, if they work with some surgeons, like a plastic surgeon or an oral surgeon, they do have some opportunities to work with them, and they work under them. Anesthesiologist assistants have to work with a physician anesthesiologist. So they do work with an anesthesiologist themselves. But majority of the times within CRNAs, we all get along very well in the anesthesia care team. So I don't see a big concern right now, like the rise of them. I think we all bring certain aspects to the care of anesthesia, to the care team model, and work well as a team. So, but I would say, yes, in the back of my mind, they do. Their society pushes a lot for independent practice, but the nurse anesthetists that I've worked with, where I trained at, and down here at Wayne, we all get along great, and we have a great work together very well. Let's see. Would you say it's possible for someone pursuing a DO? Oh, yes. So the doctor of osteopathic medicine, there are you can go into any specialty going to medical school, the osteopathic route, and that is perfectly capable. They're very well trained, and I've had many colleagues that went to osteopathic medical school and are great friends of mine. So yes, you have plenty of opportunities to do that. Okay, let's see. What do I like the most about anesthesiology? I do like the critical care aspect. So providing critical care medicine in the operating room. I have the ability to take care of patients, keep them safe during anesthesia so they can have their surgery, as well as get to do plenty of procedures. So the nerve blocks, the arterial lines, central lines, echocardiography, those types of things. I get those opportunities. So that's what I enjoy the most. What I like the least, there's really not much, to be honest. I think it's a great specialty, and I enjoy it very well. Any major changes coming to the field? From a providing standpoint and administering anesthetics, we are looking at enhanced recovery after surgery. It's I'm gonna call it a platform that has been introduced 5 to 10 years ago, and it's gradually building a lot of gain to where we're seeing better ways to take care of patients, still being safe and using that, but there's added techniques to help with pain control, nausea control after surgery, to make them feel better, get them up walking, getting them recovering quicker, and getting them out of the hospital. So enhanced recovery has allowed us to do surgeries as an outpatient and doing them on the same day rather than having the patient admitted to the hospital, because we're providing better pain control and better nausea control. And they're able to move their bowels easier and things. What traits make a great anesthesiologist? I think it's someone who is detail oriented, a great team player, and enjoys coming to work every day. And those are great anesthesiologists. How did you stay motivated from undergrad all the way till you finish residency? Whew, that's a big question right there. I think I had a great support system and staff that was there. I mean, not only from my residency colleagues and my medical school colleagues and undergraduate, but I had a great family support system. I'm very thankful for that, and that's what pushed me along the way. And at the end of the day, it was also a career aspiration of mine since I was very young. So with that, I just kept grinding. There were plenty of times that I got, beat down and tests that were hard and didn't score the way I wanted to score and things like that. But those are the challenges that you have to be presented to in your training to overcome them and develop that. What is the biggest myth about this specialty or misconception? I'm gonna have to think about that one, so I'll come back to that. Michelle, if I don't come back, remind me. I think you asked a question. Let's see. Samantha asked, what sparked your interest in anesthesiology as opposed to orthopedic or cardiothoracic or some of the other specialties? I'll go back to how I got introduced to it. It was about my end of my first year of medical school, and I went to a local Academy of Medicine meeting. So it was in Richmond. It was the group of physicians in the community that get together to work on health policy and things like that. And so just a local group. And I met my chairman at the time, Dr. John Butterworth, and he's a great mentor. He recently retired, and he talked me into it. He talked to me about anesthesia. I had experience in emergency medicine and enjoyed the rush and the thrill that can occur during anesthesia and taking care of those critically ill patients during that time. And so with that, the ability to do procedures, the work-life balance within anesthesia is, I think, really nice. I'm very fortunate now that, I do get post-call days off. I do get, much more vacation weeks than I did as a resident. So I think all those things played a vital role into why I chose this specialty. Let's see. Craziest thing you've experienced as an anesthesiologist, which I think that question also goes down to the toughest case you've had. And a lot of times those cases tend to be the emergent cases that come in, traumas, major strokes, labor and delivery. Those types of cases come in, and I think probably the toughest one, again, crazy thing was probably a massive trauma patient that came in with, and if I recall, it was multiple gunshot wounds, unfortunately, and we gave upwards of 30 to 40 units of blood products, if not more than that. And there are plenty of other patients that received even more than that prior. But we do these types of cases and take care of these critically ill patients because at the end of the day, it's rewarding when you are able to resuscitate them And yes, it may be months before they get back home, in between of being in the ICU, then staying in the hospital for months at a time, having multiple surgeries to repair X, Y, and Z. If that's broken bones, stomach, bowel injuries, things like that. But then they're able to leave the hospital and go home. Now, yes, their life may have been flipped upside down and have some things they still are recovering from, but they're able to come in almost dead and you're able to resuscitate them. And those are the things that are rewarding. And when you're able to do that. The other thing that's very rewarding, and I do like obstetric anesthesiology and taking care of moms that are pregnant, because it's a very rewarding time when you can assist not only in providing pain relief during the labor process, but then to have a newborn be delivered right in front of your eyes. It makes a beautiful cry when they're delivered. And those things are very rewarding to see that. What do you wish you knew then that you now know, or that you know now? You wish you knew. Well, it's hard that I haven't been in practice as an attending for very long, not even a year yet. So still a lot of stuff that I'm learning every day. But if I was in your shoes, is to know that no matter what specialty you choose, medicine is a very rewarding career. It is very fun. It is demanding, and you do have a lot of work to get where you are, a lot of training. But it's very doable. You got to just keep grinding. But at the end of the day, the light continues to get brighter at the end of the tunnel. I remember telling myself that all through residencies. It does continue to get better. I think I was going to go back to that question. Biggest myth about the specialty. Well, I think it actually comes about, I was reading an article last night from one of my colleagues that he had shared, and anesthesiologists are, the joke around that is we're lazy and we sit back with our feet up doing our crossword puzzles in the operating room, and that's not the case. We are perioperative physicians. We are critical care physicians that take care of patients during surgery to make sure they're safe, that they have a great outcome after their surgery and continue to do well. So I think that's one misconception. The other one is that we cancel cases, that's our job. So it's funny, we joke with our surgeon colleagues that when they bring patients in, that all we're doing is trying to find a reason not to do the case. And that is a total myth and misconception. We want to make sure patients are safe and they have good outcomes. And in order to do that, patients that have other medical comorbidities that they're taking medications for, heart disease, things like that, they may need extra things to be done prior to going to surgery to make sure they're safe. So we want to make sure that we're not here to cancel a case. We're actually here to get the case done, but make sure that the patient's safe and looked after. Let's see. What are some challenges you experienced during your medical education and training that you really didn't anticipate or think before you started? So I think that goes back to the question or the comment that I made about the testing. It's going up through high school, undergraduate, and so forth. Making really good grades and passing classes with A's most of the time was something that when I got to the challenging course, and I just remember biochemistry was in college and in medical school was probably the hardest class I've ever taken. And I did not do great in that class. And it was, that was the challenge. And so how did I go at it? I reached out for help. So that is one thing that people, I think, physicians don't like to do is they don't want to admit a fault. They don't want to admit that they may be weak in some areas and struggle. And we have to do that. And that's every individual. No one is perfect. And so you have to ask for help when needed. And so when I hit those challenges in my training, I went to the expert, or I went to my mentor, and I said, hey, I need some help with this. And so even in medical school, I had to get some extra help and some tutoring that went through and for my biochemistry course. And I just needed someone to explain it to me better than for whatever reason. And it helped click. Now, do I use all that organic chemistry and biochemistry today as a practicing anesthesiologist? No, I don't go out and draw the chemical compound of the medications I use, but it is part of the training process, and over time it helps you build that basic foundation to get where I am today. So to get back to the question, how did I go out meeting those challenges, is I faced them head on. I reached out for help when I needed it and wasn't afraid to. And if you do those three things, you can succeed and finally have that big support system around you and reach out to those friends. I think the biggest challenge as a new attending has been the transition from being a resident to an attending. And the reason that's different is because as a resident, I'm doing my own cases. So I'm in the operating room with one patient at a time, doing this with the surgeon and my colleagues, and we're doing the case. And I'm supervised by my attending. Now that I've transitioned, I'm more or less on my own. I'm making my own decisions to take care of this patient. So how do I want to take care of this patient, for example, that needs to get, unfortunately, a toe amputated and taken off because it's infected? Well, some people may put the patient fully to sleep, but my own personal opinion is I do it under nerve block. I use the ultrasound machine. I numb up 2 nerves, it's 3 nerves, but 2 injections, and I numb everything below the knee. And they're able to have their amputation done with some gentle sedation, and they do very well. And then their pain control is much more extended. They don't have to take as much narcotics. Now, when that nerve block wears off, they do. But those are the challenges I think that I've seen, was just transitioning of not only being in my own room, now making my own decisions for patient care, and not having the attending to ask the question to, hey, is this okay? Can I do this? But the other thing is the supervision role. So like I talked about, anesthesiologists lead the anesthesia care team. And that care team I talked about is either consists of an anesthesiologist and a nurse anesthetist, as well, or an anesthesiologist assistant. And with that being said, we all work well together. But that transition is now I can supervise up to 4 nurse anesthetists at a time. So any given day, let's put, for example, yesterday, well, it was a good day and I didn't have as many rooms starting out the morning, but I may get to the hospital at 6:20 and I may have 4 patients to see and 4 cases to get started, all at near around the same time. And so with that, I may have a patient, I may have 3 operating room cases, and I may have to go upstairs for OB to do a C-section. Well, it's hard for me I got to see all those patients, come up with the anesthesia plan, work with the nurse anesthetist, because we all work well together in a sense that we all know what we're going to do, usually, because we've been doing it for so long, and come up with the best plan. Well, with that being said, it's hard to be, you can't be in 4 places at once, can't really be in 2 places at once. So you have to try to stagger them. And so that challenge was trying to supervise all those and make sure things get started on time, that we continue moving forward, and so forth. And we don't delay, so we try to stagger these cases as much as we can with a short period of time. We get off to sleep and then we're on to the next one. So that was the big challenge in transition, but it's definitely been easier than I anticipated. It was definitely something that, during residence they want to experience, and I didn't really have that opportunity too much. But with my partners here in the practice at Wayne, they definitely provided me some good mentorship to help me transition.
Well, I think those are all the questions. We can wrap up a little early. Thank you so much for being here, and thank you to everyone else for being here. I think we all learned so much from your PowerPoint and your experiences. Do you have anything else you want to say?
Well, I want to say just like, if you have any questions anytime later, feel free to email me, and then keep working hard. Now, are y'all in undergraduate at Chapel Hill, or are we in some of y'all in medical school? What's the group here? So we got about 30 people.
I think the majority is undergrad, but I know we have had a couple med students join us before, but I'm not sure. Most of the time it's undergrad. So
perfect. Like I said, the one challenge that may be to reach out to me is I'm not on campus. It's very rare that we come up to Chapel Hill. So I do have the opportunities occasionally to come up there and work. But since starting down here, I haven't been up there yet, just because they need me down here more. And it's where I've always planned to be at. But I do have the opportunities occasionally to come up there. So, but at the end of the day, if you want to travel down to Goldsboro and shadow, we are able to facilitate that. And I'd have to go through the appropriate steps and things like that. So with undergraduate classes, it may be easier to get on campus in Chapel Hill at Med Center. But if someone wants to come down here and see that, we can provide those, because we do have some medical students from Campbell University's School of Osteopathic Medicine. They do work with us. And so we usually have one a month. And so we do have some opportunities there if someone would like to come down.
Yeah, well, that's awesome. Thank you so much for the opportunity. And like you said, I think everyone has your contact information. So that's great.
Perfect.
Thank you so much. Have a great day.
You're welcome. Y'all have a great afternoon. The weather, I just looked, when my wife looked, says about 70 degrees outside, at least down here. So,
That's so nice.
Go and get out and enjoy the weather, because you're not going to probably get it for a couple weeks. So
yeah,
it's probably going to get colder a little bit, but go ahead and enjoy the afternoon.
Thank you. You too.
Take care.